Welcome to Targeting Asthma, community-based strategies to enhance care, access for children, adolescents, and adults, with a focus on social determinants of health and inequities in care, presented by the Postgraduate Institute of Medicine in collaboration with the Asthma and Allergy Foundation of America, broadcast simultaneously in Immunology Live and Res Insights Live. My name is Kenny Mendez, and I'm the president and CEO of the Asthma and Allergy Foundation of America. Today's session is interactive, allowing us to take your questions in real time through this presentation. We encourage you to enter your questions at any time in the box below. I'd now like to introduce my co-presenters, Dr. Janet Phoenix, Assistant Research Professor at George Washington University and the founder and manager of the Asthma Home Visiting Program, and Dr. Sydney Leibel, Assistant Professor in the Division of Allergy, Immunology, and Rheumatology in the Department of Pediatrics at Herbert Wertheim School of Public Health and Longevity Science, University of California, San Diego. Thank you both for joining me today. Let's get started. Here are our disclosures. And then let's go to the learning objectives for today. There are three of them. One, define strategies to enhance access to individualized care among people of racial and ethnic minorities. The second, identify patients with moderate to severe asthma who may benefit from targeted biologic agents based on identification of comorbidities, endotypes, and phenotypes that are associated with underlying type 2 pathophysiology. And three, identify the place of type 2 targeted biologics in the management of people with moderate to severe asthma based on current evidence. So let's first start with asthma disparities in the United States. AFA did a disparities report and a 15-year update from one we did in 2005, and we released our asthma disparities in America report in 2020. It examined changes since the 2005 report, and what are the strategies that we need for systemic change, what are the guidelines that we need to do, and what do we need to do to promote sustainable action. When we looked at the two reports, we wanted to know what has changed, and really not much. If you look at the prevalence, mortality, and emergency room visits, they've all been the same. Puerto Rican Americans are still diagnosed twice as much as white Americans. Black Americans are 3 times more likely to die from asthma than white Americans, and Black patients are 5 times more likely to be treated for asthma in hospital emergency rooms when compared to white Americans. When we take a look at the prevalence of asthma, here are some graphs that you can look at. In the bottom line there is white Americans, the middle line is Black Americans, and the top line is Puerto Rican Americans. And so you see the prevalence is quite high. There's still a big gap between the top line, the middle line, and then the bottom one, which is white Americans. If we look at the next slide, we look at asthma-related deaths by sex, race, and ethnicity. And when you take into account sex, Black females have the highest rate of fatality due to asthma, and this rate is nearly 4 times the asthma-related death rate among white males. And AFA, the Asthma and Allergy Foundation of America, has launched a Black Women in Asthma program in order to address some of these issues. If we look at ED visits here, you'll see the top line here are Black Americans. This is information from the CDC over time. And you'll see the bottom line, the green line here, white Americans. You'll see the gap there, still 5 times more likely to be treated in emergency rooms for Black Americans versus white Americans. So continuing disparities over time, that gap is still there. So the root causes of asthma disparities, there are a number of them here that are in our report. There's social determinants, structural determinants, biological determinants, behavioral determinants. You'll see the detail here. I won't read them specifically, but you'll see them here, and much of our presentation relates to this. So with that, I'd like to turn it over to Dr. Phoenix. Thank you.
Thank you very much, Kenny. I'd like to talk a little more about the role that social and structural determinants of health can play when we compare it to things like access to care and behaviors that patients with asthma engage in that may influence their asthma. And I want to point your attention kind of to the four big buckets that include these factors that can influence asthma, the development of asthma, and asthma morbidity. So, you know, health behaviors and clinical care are kind of the two at the top. And so these are factors that have to do with our care delivery system. They have to do with access to care, and then things that individual patients do that influence their behavior. Together, those account for about 50% of what we see in terms of asthma. The other 50% is really determined by what we're calling social and structural determinants. So things like education, employment, family and social support, as well as the physical environment, things like the quality of the air that we breathe, and housing factors that we know play such a big role in terms of asthma are in that physical environment category. So when you combine social and economic factors with the physical environment, that's the other half of the equation. And people are often surprised to see that social and economic factors, what we call the social and structural determinants of health, when combined with the physical environment, really make up about 50% of what we see in terms of asthma. So I want to talk a little bit about access to care, because we often talk about insurance status as being strongly correlated with access to health care. And you can see from this slide that Caucasians in the US have higher rates of insurance than Blacks or Hispanics. Bear in mind, however, that other factors can overwhelm insurance status and have an influence on asthma. Kind of, you know, thinking back to what we were saying in the previous slide about the role of social determinants, that sometimes even in places where access to care and health insurance rates are high, you may still see high rates of asthma. The nation's capital is a good example of that. We have some of the highest insurance rates, but we also are an asthma capital, which is a distinction that is not a good distinction to have. Access to primary care is important. And just as in the previous slide, you can see that there are racial disparities in access to primary care, similar trends to what we were seeing in terms of insurance, with Hispanics and Blacks having a higher percentage of people who lack a usual source of care. There is a strong link between poverty and asthma. So people whose income is less than 100% of the federal poverty level have some of the highest rates of asthma. And people who are in that highest group, those whose incomes are greater than 450% of the federal poverty level, have some of the lowest rates of asthma that we can see. So clearly, poverty plays a role. And of course, poverty tells us that people have limited ability to obtain medications. They may have limited ability to follow through on healthcare recommendations that their provider may make. Moving on to the role of the physical environment and housing. Really, the places where people live have a tremendous impact on their health. It's the quality of the housing as well as the stability and affordability of the housing that make a difference. And for people whose income is low, they're spending a higher percentage of their income on housing, particularly on rental housing. And so that leaves less money to do things such as purchase medications or the things that can make it easier to administer medications such as spacers. It just makes it much more difficult for people to engage in activities that are going to help in terms of promoting good asthma management. And in addition, the conditions inside housing, we know, can expose people to environmental asthma triggers. Things like cockroaches, dust mites, moisture and mold are much more common in low-income housing, and maintenance is associated, or lack of maintenance is associated with higher exposure rates to these factors. Lastly, air pollution. Low-income people are much more likely to live in neighborhoods where air quality is poor. This is due to proximity to highly trafficked roadways and exposure to traffic-related air pollutants that are not only associated with asthma exacerbations, but recent evidence suggests that people who live in places where the air is heavily polluted, those populations are also more likely to have their members develop asthma. So there's an association not only with exacerbations, but also with the development of asthma. The placement of facilities like polluting industries, oil and gas refineries, disproportionately exposes Black and Brown communities, especially to conditions of poor air quality. Lastly, the cost of managing asthma places more of a burden on the poor than it does on those who are wealthy. Asthma expenditures can actually be higher for low-income people, with the cost for managing their asthma higher for those who are in the lowest economic category. This could really reflect higher rates of asthma exacerbations for the poor that flow from the conditions that they're exposed to, triggers in their physical environment. So I'd like to hand it over to Dr. Liebert now.
Thanks so much, Dr. Phoenix. I'm going to next be talking about asthma management in the clinic, and specifically targeted biologic therapies in the context of health disparities. I'll be using a couple of cases to illustrate how we manage asthma, starting with a pediatric case here, a patient with asthma and atopic dermatitis. There will be a few interactive questions in this part of the talk as well. And just so we are all on the same page, I'm basically speaking from my experience as a co-director for the severe asthma program at Rady Children's Hospital in San Diego. And this clinic that we have set up is meant to address children and adolescents that are on high-dose inhaled corticosteroid medications and still having frequent asthma attacks that lead to ED visits and hospitalizations. And our clinic, as it's set up, is a multidisciplinary clinic that includes the allergist, pulmonologist, pharmacist, respiratory therapist, and a nurse or nurse practitioner for case management. And so we're able to perform a pretty comprehensive evaluation of the patient. And we also try to address social determinants of health and quality of life. And our program has been supported by AFA. And I don't think we'd be able to do what we've done without their support. And I don't think we'd have as good outcomes as we've had if we didn't look at social determinants of health and health disparities. We also have an asthma home visit program, which has been virtual for the last 2 years since the start of the pandemic. And we've seen approximately 75 patients through Zoom visits. And we look for allergy triggers, as well as provide resources to families in the community. And again, with AFA's help, we've been able to provide dust mite encasements and air purifiers when indicated. And so our goal for the overall program is to reduce medical, psychosocial, and economic impacts associated with asthma. And so with that, we'll get to our case. This is Brandon. He's a 10-year-old Hispanic male who's being seen in the clinic with his mom. And he has persistent asthma and mild to moderate eczema. And he's had skin testing, which shows he's sensitive to dust mite. He's currently on a high-dose ICS LABA, but he still has had 2 recent viral-triggered asthma attacks that required oral steroids, and he's using his albuterol every day throughout the day. And he's had PFTs, and he's also had FeNO, which came back moderately elevated at 32 parts per billion. And so it's not entirely surprising to hear that Brandon has sensitization to dust mite. In fact, most kids that have asthma do have allergic sensitization, up to 85%. And that allergic sensitization can often precede asthma and confers a risk for persistent wheezing. And so many of you have seen this chart on the upper right. It depicts the atopic march. And that's where we see eczema and food allergies present really early in life, around 1 to 2 years of age, and then asthma and allergic rhinitis. And these trends are consistent enough that we actually use them as part of our asthma predictive index, or API. And that's for patients younger than Brandon, more in the 2 to 3 year old range, where you have a toddler who's coughing or wheezing. And we use these factors to determine whether they're going to wheeze at 5, 6 years of age. And you can see the two categories. There's major and minor criteria. And the major criteria include eczema and allergic sensitization. And on the right, you can see the minor criteria include food sensitization. And so having this information and being able to look at these trends is helpful when we're starting a patient on inhaled corticosteroids and we're talking to their families in particular about how long they might be on these medications. And now I'd like to take a little pause and we'll have a listen to a caregiver story for a patient with severe asthma.
When they diagnosed Isaiah with asthma, they initially told us he had severe asthma because his was so severe, and we had so many. We're having such an initial difficult time and so many hospital visits, and it was hard initially managing his asthma and getting the full thing under control. So initially, the asthma, he had eczema earlier on when he was younger. So the asthma and the eczema would kind of work together. He'd get itchy, and that usually meant maybe something was coming on. Then he would start like usually coughing, and a cold would start to, develop, and it would all just kind of work together.
Yeah, so the story you've heard is one that we commonly hear in our clinic, and asthma tends to occur with these other allergic conditions in kids, so eczema, allergic rhinitis. And so around the same time that the asthma predictive index came out was when we started looking at actual asthma phenotypes. Asthma isn't a monolithic condition; it's quite heterogeneous, and so the earliest phenotypes that we identified were related to timing of symptoms, early, late, and then whether the symptoms were transient or persistent. Now we also look at pulmonary function tests. We look at biomarkers that are available to us to look at different phenotypes. More recently, we've actually started to now look at endotypes, which consider the causative pathways involved in the phenotypes that we're seeing. And there's not a lot of studies in underserved populations for asthma, but one that's been around for a while and is quite good is the Eureka study, which is a birth cohort, a high risk for asthma birth cohort that was undertaken in New York City, Baltimore, Boston, St. Louis. They looked at families coming from higher poverty areas and that were at risk for developing asthma, so the parents had an atopic history. And so they followed them out for 10 years, 10, 11 years, and looked at the ones that developed asthma. And maybe not much of a surprise, the most common phenotype that they saw was a high wheeze, high ATP, low lung function group. You can see in the diagram on the right. And when they looked at nasal epithelial cells, so you can look at patterns of inflammation and these genetic modules, as they called them, they saw increased type 2 inflammation, which is what we'd expect. And they saw upregulation of genes like MUC5AC, which is under the influence of IL-13, which is a T2 cytokine. They also saw other phenotypes, however, like this moderate wheeze, low ATP group on the left side of the diagram. And that phenotype was more associated with increased epithelial injury and decreased antioxidant activity. They also found an association with early exposure to maternal depression in that group. And so the asthma, as we see, is quite a spectrum. And considering phenotypes and endotypes is really important when we consider asthma pathogenesis, how asthma develops, and then how we are treating it, how our patients may respond to our treatment modalities. And so when we see a patient like Brandon in our clinic, the first thing we're going to try to do is confirm the diagnosis. And we try to get a good history and exam. What we're looking for is cough, wheeze, shortness of breath in the context of an allergen exposure, exercise, or stress. And usually they've been prescribed an albuterol inhaler at some point, and we'd expect them to tell us that they've responded to that medication. If we don't get those points of the history, then we start to consider a long list of masqueraders, and there's a list of them on the right there. We also use spirometry to help aid us in making the diagnosis of asthma in kids. What we're looking for is reversible airway obstruction. Diagnostically, we're looking for an 8 to 10% improvement in the FEV1. And so someone like Brandon might have a PFT that looks like the picture in the middle. That's a flow volume loop. At the top part, you can see the expiratory part of the loop. It looks like someone's come in and scooped out with an ice cream scooper. You give them a couple of puffs of albuterol, and we hope to see an improvement so they look more like the diagram on the left. Also, we can pick up other conditions like vocal cord dysfunction. As the name implies, that's upper airway. That's an upper airway issue. And so we can look at the inspiratory part of the loop, which is on the far right figure. And you can see there's blunting on the edges. Just to make things a little bit more tricky, vocal cord dysfunction and asthma can certainly coexist in a patient. And children can also have a normal FEV1 and still have significant asthma. So you kind of have to take everything together. We often do further testing like allergy testing, which I mentioned earlier. We can do imaging, chest x-ray, CT imaging, get sweat chloride test if we're thinking about cystic fibrosis. So when it's useful to have a pulmonologist on our team, can get BAL fluids. We've actually been able to diagnose a few cases of EGPA in our clinic and published on those based on their responses to biologic therapies. Just a quick note on phenos. The American Thoracic Society guidelines suggest that phenos can be used for detecting eosinophilic airway inflammation. And it suggests that a patient would be able to respond to corticosteroid therapies. And so we'll often get them in patients we see for the first time in clinic. And then we'll repeat them on subsequent visits because steroid treatments tend to reduce the pheno level. If we don't see the numbers coming down, then that suggests that maybe they're not taking the medication. But a couple side points are that pheno can remain elevated if there's other factors than non-compliance with medication, including if there's a lot of an allergen exposure, or if in Brandon's case, you have eczema or other allergic conditions that also can elevate your pheno. And so again, we need to take these numbers in the context of the clinical presentation. And so our severe asthma clinic, what we try to see in our clinic is uncontrolled asthma despite high dose ICS use. It's actually a small percentage of those with asthma, only 5%, but they account for 50% of the healthcare utilization because of their ED visits, because of their hospitalizations, because of the ICU admissions. And so once we're more comfortable with the diagnosis, we try to differentiate between those that have modifiable factors or difficult to treat asthma on the chart going to the left below there. And then on the right, those that are severe therapy resistant asthma patients, and that's what we're considering biologics. This is a picture of the 2000 LBI guidelines for asthma severity. This is looking at youth and adults. It's the same for school-age children, essentially. When we look at severity, we are looking at two domains, risk and impairment. The impairment domain is kind of your day-to-day symptoms, your cough, shortness of breath, wheezing that require albuterol use. You can also use FE. You can also do PFTs in kids that are old enough, I'd say 5, 6 years of age, that can do them reliably to kind of gauge severity. And once the symptoms are occurring daily or throughout the day, that's when we're in the moderate to severe category for impairment. Then we also have the risk domain. That's looking at exacerbations that require oral steroid courses. And we have a lot of patients, a lot of pediatric patients who are fine in between their exacerbations. They don't have regular symptoms, they don't have a lot of impairment. However, when you look at their records, they've had 3-4 oral steroid courses in the last year, and they're still being called intermittent mild asthma. And so it's important to consider the risk domain when we are classifying patient severity. Based on the severity, we then are able to assign them to stepwise treatment. And so for a patient like Brandon, we're thinking about step 4, 5, 6 in the lower part of the chart here. And so now we'll take another pause here to do an audience polling question, and I'll read out the question for you and give you the answers. Starting with the question, which is, which biologic, if any, would you recommend to better control Brandon's severe persistent asthma? The choices are A, dupilumab, B, omalizumab, C, reslizumab, D, I would not recommend a biologic at this time, or E, unsure. And so they actually recently updated the NHLBI guidelines in 2020. And, if we look at sort of where Brandon is, he's at step 5 and going towards step 6. And so you're either thinking about starting him on oral steroids, which I can count on my hand how many patients I have on daily oral steroids, or you start to think about the biologics like omalizumab. Now, even though this is a 2020 update, a lot of the biologics have become, the indication has dropped to 6 years since this update. And so even though this is a more recent update, it's still a little bit behind. The other changes to this to the guidelines are related to inhaled corticosteroid use and more specifically using them in combination with a long-acting beta agonist. And so what's identified as the SMART therapy, where you're using single inhaler ICS LABA for your controller and your reliever medications, is now sort of preferred treatment plan option. The other things that they changed here, they made considering allergy immunotherapy sort of something you think about for steps 2 to 4 a little bit more prominent, and looking for environmental allergens and controlling those. And both those things make sense given how the frequency of allergic sensitization in kids. And if you treat the allergies, then the asthma might get better without having to go up on the medications here. Then we also have the GINA guidelines, which are a little bit different, starting with the ages. They start at age 6 and NHLBI starts at age 5. But generally we call this school age children. And what you'll notice, in addition to sort of having the different biologics that are actually available, is that GINA no longer distinguishes between intermittent and persistent asthma. And the rationale for that is in part because patients with intermittent asthma can still have very severe asthma attacks. And so what they are starting to introduce is the idea of using an inhaled corticosteroid whenever you have recurrent wheezing or persistent asthma, along with a short-acting beta agonist. And so we have our answers back from the polling question. Omalizumab is what most people, the majority of you, have chosen, which is, in my mind, the correct answer. For the choices that are available, dupilumab might be another option, but I do like to keep that one in the back pocket in case omalizumab doesn't cover things. And so getting back to treating inflammation and the bronchoconstriction that we see, it kind of makes sense when you think about T2 inflammation. Classically, we think about dendritic cells that present antigen to T cells that, under the influence of IL-4, become skewed towards Th2 cells, and they release mediators like IL-4, 5, 9, and 13. These go on to induce B cells to class switch to IgE. IgE can then cross-link on mast cells. That's in the middle of the chart here. Sorry, this is a very busy slide. And that cross-linking leads to the release of mediators like histamine tryptase that can lead to the smooth muscle cell constriction and and why a bronchodilator is useful. But there are also these other mediators that are leading to goblet cell hyperplasia, and increased permeability and increased inflammation in the airway. So we need to treat those as well. We now know that like damage to the epithelial layer itself, epithelial cells, can lead to the release of alarmins like TSLP, IL-25, and IL-33. Those can activate dendritic cells, but also a newer class of innate immune cells called ILC2s. ILC2s can basically act like Th2 cells and release IL-4, 5, 9, 13 as well, and they can induce B cells to class switch IgE. They can activate mast cells. And they, along with Th2 cells, can release IL-5, which we know induces eosinophilia. And these patients that have this sort of inflammation can have more of a eosinophilic asthma picture. And so now we know that, now that we have a better understanding of the inflammatory processes that are involved, we actually have a whole slew of biologics that are now available to us. I'm most familiar with the three in the middle: dupilumab, mepolizumab, and omalizumab. Those are the ones that are available to young kids 6 and older. Omalizumab has been around the longest, and you need an IgE level, and based on that level and the patient's weight, then you dose it. And if a patient's particularly obese, or then you may not be able to use omalizumab. And the safety features that we consider include anaphylaxis. And so we do prescribe an EpiPen for these patients. I've never, fortunately, seen someone have that reaction. Mepolizumab is every 4 weeks, which is nice, but you do have to watch out for helminthic infections. Again, we might start IL-5, a drug that targets IL-5 when we see more of an eosinophilic asthma picture, and so their eosinophils might be elevated on a CBC with differential. And then dupilumab, which targets IL-4 and 13. Like I said, I generally start with omalizumab, but then we can go to dupilumab if omalizumab is not doing its thing. I have seen conjunctivitis with dupilumab, and it is useful if there are other indications. You see that you can use it to treat those with moderate to severe atopic dermatitis and those with polyps. And then the latest one, tezolizumab, binds to TSLP, and so I haven't prescribed that as of yet, but it does show promise given its role in T2 inflammation in asthma. And so if Brandon's atopic dermatitis had been moderate to severe, would you recommend a different biologic? And so this is another audience polling question, and the choices are A, yes, B, no, and C, unsure. And so we'll give everybody a couple minutes to respond to that one, and I'll keep moving along. And so our next case will be an adult case, which I don't see as much of in our clinic. However, we do have adolescent patients that go on to that should be transitioning to the adult side, but they still want to be seen on the pediatric side for a couple of years. And so we do see some kids that are 20, 21 years old. But this patient is Anita. She's a 39-year-old female with asthma and nasal polyps. She's of African descent. She has steroid-dependent asthma and comorbid chronic rhinosinusitis with polyps. She's tried the ICS-LABAs, and she's also on daily oral corticosteroids. She can't taste her food, and ENT recommended irrigation and ultimately surgery, which she had done 2 years ago, but as polyps often do, they came back. And so this is the NHLBI guidelines for adolescents and adults. There is not a whole lot different from the school-age children other than at step 2, we consider the option of an as-needed short-acting beta agonist and inhaled corticosteroid. And then it goes into SMART therapy for step 3 and 4. They again reiterate using subcutaneous immunotherapy and allergen mitigation interventions. The other biologics that are available, you can see now, are available sort of the bottom part of the chart. And as I mentioned, many of those are now available to to 6 and older in that group. We also do have the answer back from the group. The majority are saying they may switch over the biologic that they're using, and dupilumab might make the most sense if there was severe eczema present in our patient. The GINA guidelines also, when you look at their updates, pretty similar to the school-age children. Short-acting beta agonists are no longer recommended for the treatment of adolescents and adults with mild asthma. And so for the reliever, they recommend using a combination inhaler. And so ICS formoterol or ICS whenever a short-acting beta agonist is used. The next slide here is, as I mentioned before, when we look at severe asthma patients, we want to differentiate, we want to be able to look at modifiable factors. And there's a list of them here that include poor adherence, inhaler technique, the environment, comorbid conditions. And starting with poor adherence, so we have the luxury of having a pharmacist that calls each patient's pharmacy and sees if the patient has been filling. We get a fill history for both controller and reliever medications, and so we have a ratio of how they're doing with their medicines. Doesn't mean they're taking them, but at least we know, that they're picking them up monthly. The other thing you can have a family do is bring in their inhalers and look at their counters. That doesn't mean the counter on the device. That doesn't mean that they're not spraying it in the air before they see you, but hopefully not. The other reason to have families bring in their inhalers is you can check their technique. And so for little kids, we want to make sure, those that are under 4, we want to make sure that they have a spacer and mask. As they get older, we want to make sure that they have a spacer mouthpiece. And then as they get closer to 6 years of age, they can start using self-actuating devices that don't use a spacer. And then for our young adults and adults, we have DPIs or dry powder inhalers that also don't use spacers. In general, I feel like patients do better with spacers from kids to adults, but there are these self-actuating and DPI devices available. Just to tell you a quick story, I had a patient who had moderate persistent asthma on a medium dose of inhaled corticosteroid, and all of a sudden sort of lost control of he had more symptoms, and we couldn't figure out why. And so we had him show us how he's using his inhaler. And so he had one of these self-actuating devices, and he opened it and got his, took the deep inhale and got the first dose, but then he didn't close the lid, which resets it, and open it again to get the second dose. And so he just took a second inhale without resetting it. And so he basically was getting about half the medication he needed. And so once we were able to kind of educate him on that, he did a lot better with his asthma control. We don't necessarily need to go up on his medications. The environments, just moving along on the list here, we want to consider, so in the home, if there's smoking exposure or allergen exposure, if they have a dog, the dog sleeps in the bed and they're allergic to dog, you kind of need to address that. But also the school setting where kids spend half of their days may be an issue. And then for adults, you need to consider the work environment. And lastly, just talk about comorbidities on this slide. Reflux, nasal polyps, obesity are all common comorbidities that we can see. A lot of these comorbidities occur at a higher rate in people of color. And so making things a little bit more complicated when we managing asthma in these populations. A lot of patients with polyps also have asthma, a large chunk of them, and that asthma ends up being in many cases more difficult to control. And then the polyps they have also occur more frequently and recur more frequently. And so it falls under this unified airway disease theory, where it's thought that the upper and lower airway disease that we see is a result of a single inflammatory process. And so with all these biologics available, and there's even more available for older kids and adults, how do you make the decision which one to use? And so EACI, which is the European Academy of Allergy and Clinical Immunology, actually came out with this decision tree to help. And on the far left, you can see these 3, what they call pillars to consider. And we've touched base on some of these, including phenotypic traits, biomarkers, and outcomes. And you start your biologic, and the important thing is to assess things after 4 to 6 months. And if they're doing well, then continue to monitor them. But if they're not, then you may need to switch to a different biologic. They may have a different form of eosinophilic asthma. The dose might not be appropriate. They might have autoantibodies. So, it's important to readjust things. They might also have non-T2 inflammation. And so that's when we're thinking about dual bronchodilators, macrolide therapies, things like that. I did have a patient who was probably the worst outcome I've ever seen from status asthmaticus, who had an unwitnessed asthma attack and actually developed hypoxic ischemic encephalopathy. And after that, she had spastic quadriplegia and a seizure disorder. She was under the care of her grandmother, who had difficulty getting her into visits and getting her medications filled. And so after we looked at her labs and looked at the logistics of things, we were able to get her on monthly mepolizumab injections that the home health nurse was able to go to the home and give. And so I think these decision trees are helpful, but I think there very much is an individual case-by-case basis that we need to be thinking about these things. With that, we'll hear from a patient perspective of someone with severe asthma and nasal polyps.
My entire life has been a struggle with the asthma and allergies, but the polyps, it definitely adds to it. It's definitely challenging, like the asthma and allergies. So I still have my restrictions, and the treatment has helped, but it's not definitely going to, solve the issue. There's no cure for it, The restrictions I have is like, even with allergies, you have to be careful in certain environments, also being around certain things that can trigger your allergies. So same with the polyps, same thing. You have to be always cautious, in the back of your head, what to be around and what not to be around. So that is a challenge every day.
So yeah, we have a another audience polling question here, and as we heard, dealing with sort of polyps and asthma is a very difficult situation, and one that we can definitely see in our patient population. So the question here is, which of the following would you recommend for better management of Anita's asthma and comorbid chronic rhinosinusitis with nasal polyps? The choices are A, benralizumab, B, dupilumab, C, reslizumab, D, tezepelumab, and E, unsure. And I'll just sort of move on while we are getting those results back to you. With the last few minutes here, I just want to focus a little bit on disparities in asthma management. And I mentioned that the importance of sort of guideline therapy, and multiple studies have shown that clinicians in general adopt guidelines to varying degrees. But specifically, Black and Hispanic patients continue to be less likely than white patients to receive guideline-based therapy. I talked about the importance of determining severity early on in asthma management, and these groups, providers frequently underestimate their symptom severity, which leads to lower rates of controller medications, which leads to more asthma attacks and asthma exacerbations and the asthma burden that we see. And so it's possible that there's unrecognized bias. It's more than possible. It's likely there's unrecognized bias and misassumptions that can contribute to this discrepancy. And it's not just in asthma, it's also present in other allergic conditions. Atopic dermatitis, allergic rhinitis are both under-recognized and undertreated in African-American populations. This is a study that was published in the last year that's actually looking at the prescription of biologic medications in the United States on both public and private insurance plans. The upper chart is just looking at a timeline of when different biologics became available in the prescribing practice. You can see omalizumab in the green has been around for a while, and more recently we see those that target IL-5, and then we also have dupilumab here. But I want to draw your attention is to the bottom chart, and what you can see is the green line, which is patients that are on public insurance have far less biologic visits than those that are on private insurance. And that's been consistent throughout the years. And so in addition, despite a higher prevalence of severe asthma in people of color, 64% of asthma treatment visits were for white individuals. And if we look at the public insurance plan specifically, although they represent 60% of those that are seen for asthma treatment visits, white patients accounted for 80% of biologic treatment visits in the publicly insured. And so, at least in our clinic, I haven't found it particularly difficult to get biologics approved for patients that are on public insurance as long as you justify the need. However, if patients are being underclassified or not getting referred to specialists that can prescribe these medications, then they may not have access to these medications that can be really helpful for them. We do have our responses back to from the previous question about nasal polyps. It looks like most of you were unsure which one you might start, but also some did select A and B. And so dupilumab actually might be a good drug, as it does have indications now for polyps and for moderate severe persistent asthma. Mepolizumab would also possibly be an option if it was on there as a choice, but it wasn't. And so getting back to sort of disparities in management. So I think we as clinicians, if we can get closer to just following sort of guideline recommendations, which can be tricky if there's multiple guidelines and they update them differently. But this is a study actually that was done in the last year that looked at reliever-triggered inhaled corticosteroid use in Black and Latinx adults with asthma. So about 1,200 individuals with poorly controlled asthma, and they did a one-time instruction of using an inhaled corticosteroid whenever they used a short-acting beta agonist versus usual care. And then they measured exacerbations, the asthma control scores, and the symptom scores. And across all three areas, those that had the intervention with the use of ICS did better. And so so how we as clinicians kind of manage our patients, I think, is one component of starting to close the gap in asthma prevalence and asthma burden that we see. But there are other components that certainly need to be addressed as part of a multi-prong approach. And so I'll hand things back to Dr. Phoenix at this point.
Thank you, Dr. Leibel. So I'm going to talk next about direct intervention programs that can really target and improve that 50% that I talked about earlier, the 50% that fall into the social and structural determinants of health bucket or the physical environment bucket. So, you know, these programs have a good evidence base and are recommended by NHLBI as part of comprehensive asthma management. And so, you know, interventions that are targeted at improving assessment and monitoring of asthma control, or that aim to improve self-management and education, pharmacological treatment, both access and compliance, as well as reduction of environmental triggers, are kind of the big four buckets that we look at in terms of these intervention programs. And successful elements have to do with comprehensive programs that really integrate a number of things, you know, medical management, education, environmental interventions, kind of all blended together. And I'll give an example later on of a program that really was successful in combining all of those into a virtual home visit. So, you know, really looking at medication-related factors that can interfere with treatment. I talked a lot about costs earlier in the presentation, but also patients' perception or their family members' perception about side effects, the ability to properly use medications. It really takes a lot of time to provide patient education instruction about how to use medications properly, and you know, the proper use of a spacer. And so setting aside the time during a clinical visit to provide this education can be challenging. And it's something that you need to think about how to incorporate that education so that it occurs when asthma is diagnosed, and also so that it reoccurs when there's an exacerbation, because that could be an indication that there's a need to go back and touch base and refamiliarize patients with the proper use of medication. Thinking about things like literacy, you know, patients who may confuse preventer and controller medications, and so they're giving the albuterol regularly and not giving the Flovent twice a day according to the recommended regimen. So I am Here we go. So it's important that there be a shared decision-making process. So part of that shared decision-making focuses on the provider. And so there are things that you can do in terms of your practice and how you're interacting with your patients to work better with patients and with their caregivers so that there is a true partnership. And so that you get the information you need to ensure that you're working as a team with patients and their family members to ensure that the care takes place and that recommendations you might make for medications or behavioral changes are implemented. So I'd like to turn to a patient story that really illustrates the importance of that communication between patient and provider.
My doctor and I, we have a very good relationship. I'm always looking into, I'm always researching different stuff. So if I see something that fits me or possibly could, I definitely will reach out, and my doctor would, contact me, and we'll just agree on it and just try it. And I mean, my doctor will call me right back. I don't have to wait a week or 2 weeks or the day of my appointment a month later. I mean, we have that closeness, and I'm definitely appreciative of that.
Make sure you pay attention to what the doctor is saying. Make sure if they're saying it in a way that's not understandable, then let it be known. Ask them to try it a different way. This doesn't make sense. I need you to break it down, bring it down, please. Just stay on top of it. Don't walk away feeling like you don't know what's going on. It's their job to treat you, not just in terms of, the medicines, but also from a human perspective, to give you that respect and to give you that communication.
So I think that video helped to illustrate some of the issues that can arise that interfere with a good communicative relationship between the patient and provider. People, I mentioned that there's often confusion about the types of medications. The color of the inhaler may be the only clue that your patient has to when that medication should be taken and what it's for. Cost is a true barrier. I conducted a home visit once with a family whose insurance didn't cover the cost of the asthma medications, and they had two children with asthma whose medications they were paying for out of pocket, and that took a big bite out of their monthly budget. Some insurance companies won't cover the medication that you prescribe, and you don't find that out until much later when the patient hasn't gotten what they needed. If there's more than one household and children are moving from one household to another, say mom's house, dad's house, the medication may not always be where the patient is. So you shouldn't overestimate the ability of your patients, especially young patients, to understand and use the proper technique. And so that underscores the importance of ensuring that education is rolled into an effective asthma management an approach for each of your patients. On the provider side, decision support tools can really help with this. I worked with one system that developed an asthma dashboard. They just incorporated the NHLBI guidelines in with order sets, decision support that would provide feedback to providers about their adherence to the guidelines, to evidence-based care, and that was extremely helpful in terms of improving their ability to adhere to guidelines and improve the care for their patients. So the asthma control test can be one tool that can help you monitor what's going on and which patients really need that extra help. And so measuring symptoms like nighttime cough or wheeze and reporting that at the time of the office visit can be helpful. I've known practices that have used a tablet in the waiting room and administered the ACT just before the patient saw the clinician, and that information really helped to guide that conversation between patient and provider. and can be a very helpful adjunct. Asthma action plans are important and of course are required in some jurisdictions in order to ensure that medications can be administered in the school environment. But these are also a teaching tool and can really help everyone who's involved in the care of the patient, particularly pediatric patients. It can help teachers and other caregivers to understand when things are going well, when to be concerned and to administer extra medications, and then when immediate action might need to be taken in terms of an ER visit. So I'd like to talk just briefly about some of the components of an asthma home visiting program. The asthma home visiting program is kind of one piece of asthma management that has a really good evidence base. These work in terms of addressing some of the environmental and home-based environmental asthma triggers that can really have an impact on asthma. This grows out of an effort, a joint effort across Health and Human Services, CDC, the Environmental Protection Agency, and HUD to really look at the impact of the home environment on health. Allergens, of course, are the things that in the home that we are most concerned about. I've listed some of them here, but this healthy homes approach, of course, looks at other conditions in the home that can impact health as well. So a 44% decline in doctor-diagnosed asthma could result if we were able to eliminate some of the unhealthy things in children's homes. So an asthma home visit really has 4 or 5 components. Integrated pest management is one of the most important, but also providing dust mite covers for the pillow and for the bed. Smoking cessation, because environmental tobacco smoke is such a trigger. The HEPA vacuums really help, especially if there are pets in the home, but they help to clean up other allergic dust particles as well. And then if there are other things in the home that need to be addressed, such as moisture intrusion that might be leading to mold, a close working relationship with agencies or organizations who can address that is a key component of asthma home visiting. This is a checklist that's often used when asthma home visits take place. And that home visiting project I mentioned at the beginning of my second set of remarks was an example, I think, of good integration between asthma clinical management and assessment of the home environment and remediation of home environmental asthma triggers. This was a grant-funded project the DC Children's Hospital was able to implement, and it included a virtual home visit on a Zoom platform where clinicians monitored the management of the child, ensured that medication prescriptions had been filled, and addressed any other medical management issues. And then that we used the phone to walk around the home and identify any environmental asthma triggers in the home. And then that was followed by an actual visit to the home to drop off supplies, HEPA vacuums, to conduct pest management if needed. And so everything was kind of made really easy for families. This was piloted during the pandemic, but this provided us with an opportunity to implement and integrate these services. So I'm going to turn it back over to Kenny now.
Great, thank you, Janet and Sydney. Those incredible information there. We do have a couple of questions for you all. I think we're close to time here, but just a few here. Maybe Dr. Phoenix, you could answer one. What are I know you covered the asthma action plan, but what are the essential elements of an asthma action plan that you feel are important?
So the asthma action plan is important to indicate the medications that should be given and when they should be administered, and also what symptoms to look for in order to increase medications. And then, of course, lastly, the red zone area of the asthma action plan provides information about when is the child in trouble, and when does specific action need to be taken, such as a visit to the primary care doctor or to the emergency room.
Got you. Thank you for that. Another question that we have here, Dr. Leibel, you mentioned this, and we covered this a little bit in our asthma disparities report, but you talked about unrecognized bias. And just for people who are out there practicing, Dr. Leibel, I was wondering what your advice would be in terms of catching yourself or understanding what unrecognized bias might be that you've seen.
Yeah, it's I think it's hard. It's a subconscious thing that a lot of clinicians have been found to do, actually, and we make assumptions because we are trying to get through. If you're a specialist, you're trying to get through a busy day, and you try to put people in boxes and try to get through things in a timely manner. But when you do that, sometimes you make assumptions about your patients, and then you end up mismanaging them. And so what I often try to do, what I mentioned with that difficult patient that I had, is I try to put myself in their shoes. And what would it be like? Why would I feel the way they feel? And so, if you look at the literature, there's people that suggest that African Americans in the clinic setting are considered to be angrier, less of a team player. Those are misconceptions, and as clinicians, if we are coming from that position, then we're not going to be able to make good decisions for the patient. So I always just try to consider things from the patient's standpoint and why they might feel the way they feel, and how can we get to a place where we're moving forward. And that's at least day to day what I try to do.
Thank you. That's really helpful. Let me just follow up on that, because there is a question that came up, which is to describe which specific biological agent should be prescribed for the specific asthma patient. So I know you mentioned that communities of color sometimes not on biologics as much as others, but maybe you could just cover which biologic agents for specific asthma patients.
Yeah, I mean, I kind of went through that, but it was quick. And so I do tend to start with omalizumab just because it has the biggest track record, unless the IgE levels are too high or they are, they may be dealing with obesity. Then I might think about something like dupilumab if they have other conditions like eczema. And then I do use mepolizumab quite a bit for those that have eosinophilic asthma. So when they have the elevated eosinophils, then I'll and not as high IgE, then I might go with that. But it is kind of logistical as well. Like some of them, the dosing schedule you want to do every 2 weeks, you want to do every 4 weeks. Are they going to come into your clinic? You're going to do it at home? And so these are decisions that are made on a case by case basis. And I don't there's not sort of a blanket statement for how you would treat them.
Gotcha. Thank you. Well, I think we've run out of time. Great answers to the questions, and thank you to the audience for the questions, and thank you both. And thanks to our audience for the great questions. This is a really important topic to AFA and to everyone out there. I'd also like to thank Regeneron Pharmaceuticals and Sanofi Genzyme for their support on this important educational activity. And please remember to complete the post-test at the end of the session to secure your CME credits. And also please visit immunologylive.com and resinsightslive.com to view today's session along with other sessions on demand. My name is Kenny Mendez. Thank you for joining us